Hi, this is Carolyn. I'm presenting on behalf of myself and Paula. Our Healthy People 2020 topic is chronic kidney disease in a diabetic patient to reduce kidney failure due to diabetes. 171.5 per million of the population reported kidney failure due to diabetes in 2007. The 2020 target goal is 154.4 million, target setting 10%. Per the website, the target has not been met. The number of cases have risen and decreased and risen again in 2016. Sources say that diabetes account for 30 to 50% of end-stage renal disease, while 30 to 40% of people with diabetes develop diabetic nephropathy. Of the many goals of diabetic treatment, controlling blood sugar and the prevention of complications on a microvascular level have a direct link to kidney disease. It is said that sustained elevated sugar levels in the bloodstream causes advanced glycation in products and lipids. This glycation gives way to the microvascular tissue injury associated with diabetes. This causes a spiraling of events with high kidney blood pressure, high systemic blood pressure, proteinuria, albuminuria, and reduced estimated GFR. Treatment for hypertension, dyslipidemia, and diabetes are the key to slow progression to end-stage renal failure. Blood pressure control to reduce cardiovascular disease should be a systolic goal of less than 140 and a diastolic goal of less than 90. ACs and ARBs should be used because they have been shown to reduce kidney failure and overall mortality in patients. They should not be used in combination because there are studies that show that it does not decrease mortality rates or slow the disease. Aldosterone antagonists have been shown to lower blood pressure, but they also have increased side effects. Diuretics and calcium channel blockers can also be used. A statin should be introduced to reduce cardiovascular risk. High-intensity statins should be used as tolerated. The A1C goal for non-pregnant adults who are less than 65 should be less than 7. SGL2 inhibitors should be used because they are considered renal protective, and if the GFR is greater than or equal to 30, SGL2 inhibitors should be used. Patients who are already on dialysis should be treated with insulin. Metformin can be used, but it should be dosed depending on the GFR. Older adults can also be treated with ACs, ARBs, aldosterone antagonists, diuretics, and calcium channel blockers, but their blood pressure goals should be higher, a systolic of less than 150 per the JNC8 to avoid hypertension. The A1C goal should be less than 8. It should be less stringent in older adults to reduce the risk of hypoglycemia. Statins can also be used to decrease cardiovascular risk in the elderly, but it needs to be dosed as tolerated. There should be a discussion with the elderly and their family members about the risks and benefits of treatment versus no treatment and the life expectancy of the patient. An algorithm has been developed to identify and evaluate patients at risk for chronic kidney disease. It includes who should be screened. Factors to be considered include race. There's some races that are more at risk for chronic kidney disease, including African Americans. Age. People who are less than 70 need to be tested. A family history of kidney disease needs to be a priority. And those with comorbidities, which include cardiovascular disease, hypertension, diabetics. What tests should be performed for chronic kidney disease? It includes chemistry, a urine albumin to creatinine ratio, and a urinalysis. A diagnosis of chronic kidney disease can be made after 3 months, depending on lab results, and a referral to a nephrologist is needed if the kidney disease continues to progress despite treatment for hypertension, diabetes, and dyslipidemia. The goals in primary care include optimizing blood pressure control, by using ACEs or ARBs where indicated, reducing cardiovascular disease risk by the introduction of a statin, identifying progressive chronic kidney disease based on the staging and regular testing, evaluation of the albumin in the urine, considering a renal ultrasound as needed, lifestyle advice, and lifestyle changes for the patient, which includes increased physical activity, weight reduction, and smoking cessation. A dietitian referral is necessary to teach and provide education on healthy eating, reduction of salt, alteration of potassium in the diet as needed. Medication needs to be reviewed with the patient at every visit, and they should be told to avoid NSAIDs and other nephrotoxic agents. And also referral to a nephrologist is needed.